right, welcome back. We have another very special guest, Dr. Perry Burstin, who's an ear, nose, and throat surgeon. Let me do a quick intro. Perry is a Melbourne University medical graduate who completed ENT training in Victoria and then a head and neck fellowship in Dublin. His practice is focused on pediatric and adult airway management and the treatment of sleep-disordered breathing. A significant portion of his work is based around sinonasal, I can't pronounce that, I'm sorry, sinonasal, is that a misspelling? Disorders, as well as functional, aesthetic, and reconstructive rhinoplasty. His other main medical interest is in third world health in the Pacific. Please welcome Dr. Perry Burstin.
Thanks very much for having me. And it's good to be sharing this very integrative platform here. I met a number of you earlier this year, and I thought it was a terrific conference where we had dental practitioners, orthodontists, fascio-max, sleep, and ENT practitioners. And I think it was an excellent way to sort of really nut out what's common and what we can all learn from each other. So what I thought I'd do here is I've titled this "What the Dental Practitioner Needs to Know About the Airway, but was too busy to ask about." And I know you can't answer me here, but I hope some of you may have seen this piece of art, and it's Salvador Dali. And what it beautifully demonstrates is the symbiosis between anatomy and beauty and aesthetics. And my journey in all this really started early on when, and I've relayed this to a number of you in earlier sessions, where I really couldn't quite understand why some people who were having platoplasty operations did well and certain ones that were doing poorly. And it was only really once I got to this schematic diagram based on Da Vinci's work that it really started to fall in place for me. And so what I'm going to do here is have a practical based lecture. It's not going to be encumbered by references, but I'm going to talk about a few things. And firstly, it's airway assessment. Firstly in kids, then in adults. We're going to talk about multi-level inputs for sleep disorder breathing, very much like Roland has done, but from a more ENT perspective. And then I'm going to share with you some permutations of nasal surgery. So the first thing is that it's mandatory to examine the patient's upper airway. And it's not hard to do. At a minimum, you need a decent light source, a speculum, a tongue depressor, and there's the saying that more is missed by not looking than not knowing. So here's me in the third world doing an EUA on an ear, but what you see is, I mean, can you see my cursor spinning around on the screen? That there is a voroscope, and it's the light source that we use in an examination setting. Here we have a thudicum speculum looking at a severe septal dislocation. Here we've just got a wooden spatula, but normally I would use some metal depressors for the oropharynx. And in kids' airways, we're really talking about three things. We're talking about the front of the nose, the back of the nose, and the postnatal space, and the tonsils. So what I think is the commonality here and the fundamental is that of mouth breathing, and we're trying to overcome that somehow. And we all know this picture of the tibial adenoid facies, of the open mouth posture, the long face, and bags under his eyes that you can't see there. So what's the problem here? We've got sleep disturbance, we've got an open mouth posture, we've got venous pooling, we've got obvious dental hygiene issues, And from my perspective, in my limited knowledge about the teeth and the mouth, the teeth is the only part of the human body that gets its immunity not from blood, but from saliva. So they've often got dry lips, they've got palatal narrowing, they've got alignment issues, and we all know about the behavioural and the cognitive issues. And something that's very poorly understood is why kids also get enuresis, and which often is solved by airway surgery. So what's the problem, as I see it, as a non-dental person, is that mouth breathing will give you distraction forces. It has elongating effects on the face. Your tongue position is obviously going to drop because your mouth's open. There's the palatal arching that occurs. You've got bruxism and dental wear, which is common and often the first sign. And you've clearly got issues that you want to try and avoid, which is orthognathic relapse and recidivism. To me, this is a very important slide, because I believe that we only have jurisdiction to insist on airway surgery to a patient if there's an incipient airway catastrophe or if there's a suspicion of malignancy. So I tell patients that these are the only absolute indications for intervention. It's the only time where I can say you must do something or something terrible is going to happen. And I think we have to put things in perspective and say that, well, these dentofacial considerations that we're talking about here are only relative indications in the overall hierarchy of the problems that we're seeing. So most of medicine is art and science. It's judgment issues. And what are the pertinent judgment issues that I think you need to consider? I think you want to look at how good do you need the airway to be? How likely will it negatively affect your results? What are the parents' expectations? Do you insist on it being improved at the onset before you embark on treatment? Or will you problematically potentially be back into a corner with subsequent recommendations of airway surgery, which I think is far from ideal? So the assessment I think you need to work out from my perspective is, how bad is this kid's breathing? What's their functional reserve? Are there confounding anatomical or developmental issues? And I think we also need to take into account that we live in a very multicultural society now, and we're seeing patients of lots of different demographics. And the two common racial backgrounds that I see that have more confounding airway issues are, number one, patients of Asian background, where they have a flatter malar and consequently a narrower nasopharyngeal area. And the other, more recently, are those of African heritage, because they're often very, very tall, but they have often quite significant retrognathia, and as a consequence, retrolingual impingement. So what can we do from a nasal perspective that's non-surgical? Well, you can flush them with some saline, you can flush them with some steroids, or you can even do nasal douches with steroids. And that's more in the case of polyposis, where we squirt Pulmicort with a rinse bottle into the nose. Other than that, you've got some of the allergy treatments, and you've got a RAST, which is a blood test to look for allergies, or you've got formal skin prick testing. And you can refer them off for potential desensitization immunotherapy, and that is either by the oral, the sublingual, which stands for the sublingual immunotherapy, or there's injections. But like in Seinfeld, where there was Bubble Boy, people can't be Bubble Boy or Bubble Girl. They can't avoid life, and they're going to be exposed to various allergens no matter what they do or how much they try. So when we look at people's noses, we're looking into the nose here, and we can see the inferior turbinate and the middle turbinate here. And what can we do to the nose? Well, there are a few things. I mean, in young kids, what I'll do is I'll do a tweak of the septum. So I'll basically just give the septum a bit of a nudge towards the midline. And that'll do quite commonly if they've got a bent septum. It just adds to the airway improvement, and I'll do that with a turbinate out fracture at the same time. So we're getting a little bit of airway room. I mentioned here septoplasty, but you know, I've rarely operated on a kid's septum under the age of 10. It's not that you can't do it, but you're going to have problems potentially with facial growth. But the main issue is really the patient compliance. How are you going to keep these kids still to suction out their nose and to do the post-operative care? You're going to really struggle. And things swell and you can get adhesions, and you can try and prevent adhesions by putting silastic splints in, but then you still got to get them out, and you really don't want to have to do another operation or give them another anaesthetic to take them out. So septoplasty would be an absolute rarity unless it was completely dislocated. So we'll tweak the septum, we'll give the turbinates a bit of a nudge out. I'll do what's called an LCT, which is a submucosal linear cautery of turbinates. That's the L, the C and the T. And that's basically monopolar diathermy, where we do a submucosal zap and induces a bit of scar. It's not permanent, but it just shrinks the tissues and gives them that little bit better airway. More recently, we've been doing what's called RF, or radiofrequency treatment, which is basically a bipolar treatment. And again, that gives you a little bit added shrinkage, gives you a lot of slough over the turbinates, which is almost like a sort of second-degree burn. You suction that out in about a week, and their airway is a lot better. And then we've got what I do more in adults, which is a powered reductive turbinoplasty. That I don't very often do that in kids, in young teenagers, unless they're really, really bad and really, really swollen. So this is an example of the radiofrequency machine that we use, and these are the probes that we use, and there's various types and shapes to do that. And this one here, that third one there, that's the inferior turbinate wand. And that's what we're doing. We're basically going into the nose. We're usually doing 3 passes at a low level, and there's an auto stop, which when it reaches a certain temperature, it cuts out. And effectively what we're trying to do is we're trying to go from a more swollen inferior turbinate to one with more room down here. This is an endoscopic slide showing large adenoids, and they're almost completely effacing the posterior choana. And this is essentially what we do for an adenoidectomy. We have a gag in, we have an airway tube in, and we curette the postnatal space. And so with an adenoidectomy, it's probably one of the best operations we do in ENT. It's probably about the least sexy one that we do, but it's probably one of the best. And it's one of the best because we're basically at the crossroads of where the eustachian tube comes in, where the nose comes in for breathing, and effectively, if we improve their nose, we improve their mouth. So it's generally done at about 1.5 to 4 years of age alone. I use a curettage method, which is time-honoured. It's done transorally. I apply some gauze with some hydrogen peroxide. I then cauterize the base if it's still oozing. And if things are really, really oozy, we'll sometimes use a diathermy apparatus, but I shouldn't moz myself, but I haven't had to use that for quite a few years. If we're trying to work out an assessment of how bad things are, Simon alluded a few weeks ago about the Mallampati score. He was an American-Indian anaesthetist, and it was really, he was trying to work out the degree of difficulty of intubation, and he'd get the patient to open their mouth, and he'd try to assess the degree of hard and soft palate visible with their mouth opening. And we can also assess the tonsil size from 1 to 4, 4 being touching in the midline. There's also another way of looking at it, which is from the tongue position rather than the palate. And there's also a Friedman's classification, which is used to essentially work out, along with the tonsils, the melanompathy and the BMI, 4 stages or 4 categories to work out how good success from the UPPP was for OSA. But again, that's we've sort of evolved from the work of the UPPP, which is more something that I did when I was training. If we're looking at the tonsils, well, the salient considerations have always been the number of attacks and whether there's hypertrophy leading to OSA. What I want to really do is change people's way of thinking that it shouldn't be just the absolute number of episodes, but we should also be considering the severity of these. And it was always that you had to have 5 or 6 attacks of tonsillitis in a year, 4 over 2 years, or 3 attacks in 3 years. And if you got to that threshold, you could be referred off to an ENT surgeon for surgery. But as I said to you a few months ago, it's the number of attacks versus severity. And you can have one attack where you don't even need to see your local doctor, you don't need antibiotics, you just got a bit of a sore throat and a bit of redness and that's it, versus another attack where you might have someone virtually wind up in intensive care with an incipient quinsy, airway obstruction, need double dose antibiotics and being on intravenous fluids for a few days. And they're both N=1. So I think that you need to look at severity as well as a number of attacks. I think we need to look at what I call the natural history. In other words, how is this transpiring over the years? If you've got that length of time to look back and reflect on. And you also want to be looking at not only the size of the tonsil, but the relative size of the oropharynx. And I think that the analogy I often use is the furniture in the room versus the size of the apartment and the house. The other thing I draw your attention to is that you don't necessarily have to be talking about acute septic episodes of tonsillitis, but you also need to consider that sometimes, and especially in the older teenagers and young adults, they can get what I call the chronic low-grade pharyngotonsillitis. And those patients have halitosis, they have lassitude, and they often have tonsillar formation, which are these concretions of food debris that smell and discharge. And what I'd also say is that tiredness may be due to the low-grade inflammatory change in the tonsils, as well as the airway congestion from hypertrophy. And so this was a Filipino lady that I took to theatre who was actually falling asleep during the consultation with me. And I don't think it was just because I was boring her to tears, but I think it was also because she had an AHI of 115. And this is the tiny slit that she's got in her airway. And don't forget, that's with the Boyle-Davis gag in and totally distracted outwards. So, of course, when she's sitting there without that in there, those tonsils were more than just meeting, they were actually compressing in. And she went from an AHI in the 3 digits to 0 after operation. So how can you do a tonsillectomy? There's lots of ways to do things. You can do the cold steel or dissection method. You can use monopolar, you can use bipolar, you can use a microscope, you can use the coblators. There's even now been a more recent push by some, especially in Europe, to do a tonsillotomy where you leave a cuff of tissue. I don't see the point in that, although there may be indications in perhaps some very, very congested and very young kids where you want to perhaps reduce discomfort, but it hasn't really been proven as yet. If we talk about nasal reshaping or sculpting, like some people who are in the marketing sphere talk about, I think that sanitizes the complexity of what is a very, very difficult operation. There's a litany of complications. Unfortunately, I've caused every single one of them, and but you try not to repeat them. So you need to ask the patient what they want. I had a patient who gave me this picture at the start of an operation before she went under. My anaesthetist grabbed it, he turned it over, and that was on the other side of it. And he looked at it, kept on flicking it from one side to the other and said, which one did she want? So you've really got to be pretty careful. As you know, in your sphere of practice, if you don't operate on a patient, they may be upset with you for a day, or if you do operate on them, they may well be angry with you for a lifetime. And it's said that operating on patients is like making love to a gorilla. It's not over until the gorilla says it's over. So you've got to pick your patients really carefully. I'm going to describe some individual techniques, some manoeuvres, some complex advanced cases, and some reconstructive operations. And so the aims of this operation is really straightforward. We basically want to do three things. It's the Holy Trinity. We want to make them breathe better, have them look better, and look natural. It's just that actually doing it is really hard. So when we talk about the nasal obstruction triad, we're talking about structural issues, i.e. the septum and the outside, mucosal, the lining, functional, which is the internal external valves, and we can combine these with cosmetic problems. My favourite saying is good judgment comes from experience. Unfortunately, experience comes from bad judgment. So these are some examples from over 25 years. And I should say that we're talking about primary cases. There are secondary or tertiary or quaternary, which are redo of others, and there's revisions, which are my own redos. So this is the anatomy we're talking about: bone, upper lateral cartilages in conjunction with the septum, and then we've got the lower lateral cartilages down below. The aesthetics in male to females, these are the angles. We generally speaking want to have a nice 3, 4, and 5 relationship of the nose. And when we're talking about taking sections through it, we're talking about caps of bone here, a more angled area at the internal valve at around D, and around the supratip, the configuration changes, and we've got to take into that account with the nose itself. So when we're talking about functional airway collapse, we're talking really around the internal valve and around the alar. Roland mentioned about the Cottle manoeuvre of distracting the lateral skin outwards. And for those, I'll often trial them at home with breathe easy or breathe right strips. So the internal valve is that area right there in the mid part of your nose. If you pinch your mid part of your nose, you'll feel really congested. And if you pull the skin outwards, you'll feel like you're breathing better. And that's because this area here is the rate limiting factor when it comes to feeling airflow move in your nose. We know that most of the airflow, about 90%, is at the bottom part of the nose, but the feeling of congestion is around that internal valve there. And so we give them some breathe right strips. This is what it looks like. And if they pull their cheek skin out, or they use this and say it looks better, and they look like they've got a very narrow nose, then I know that what we're probably going to want to do is try and get that part of the nose working better. And so the problem with the old style operations is when they took the top off the nose, when they took the top off the egg out, then what happened was they disarticulated the upper lateral cartilage from the septum, and this part here would simply collapse in here. And this is what's given people what we call the inverted V deformity. So if you look at Michelle Pfeiffer's nose, you'll see how it's really quite pinched in the middle part of the nose. And so what we've done is try to somehow reconstitute this internal valve here, and there's lots of different ways of doing it. So the first is a spread of grafts, and they can be tunneled or tapered, or they can be in series and wide in the middle third. So these are much bigger types of spreader grafts inserted between the septum and the upper lateral cartilage. And I'll do this for reconstructive manoeuvres. I'll try and use more cantilever type of grafts or much thinner grafts if I don't want to widen that middle third. And these are the type of, so this is a lady who's had previous nasal surgery. They've taken the top off the nose, they've sunk her here, and what we've tried to do is reconstruct that mid part of the nose. And here you can see we've put grafts in here and here to get that middle third of the nose looking normal again. In someone where we're trying to take down the bump of the nose, again, if you just take the top off the egg, you're going to collapse the nose. So you want the good profile, but you also want that mid third not sucking in. Here we've got a mid third that's twisted, and so we're going to put eccentric spreader grafts in to help with alignment and straightening and valvular repair. Here, a person whose nose is very thin in the mid part of the nose, we put this in here to get this nice brow aesthetic line so that it's harmonious. And this is this lady here, where here she is pre and post on frontal, and here she is on profile. Again, noses where we're reducing large dorsal bumps, unless you want to cause a major iatrogenic middle third deformity, you've got to somehow get that mid third of the nose looking better. And again, another profile. Here again, a thinner nose. Again, we're just giving it that nice, normal, smooth contour, and that's what we're after. Again, and here what you've noticed here is that if I can add a little bit of tissue here, it means I have to reduce less there. So by adding here and subtracting here means that I'm going to have caused less interference with that internal valve, which is the treacherous part of the operation. And here we've got this patient in frontal view. How do we improve the support of the nose? This is an open approach septal rhinoplasty. We've made a cut in the columella, we've lifted up the nose, and we've got a supporting graft in here to stop the nose collapsing down. And so here what we've got is a nose that's a bit deep here, a bit prominent there, and falls away. Really good noses lead with the tip. And you can see here that nasal tip is more refined. When we talk about the external valve, we're talking about what's happening at the apertures. Now, sometimes the aperture compromise is actually from the septum. And you can see here we've straightened the septum and suddenly the external valve is improved. Here again, 3 previous operations, we've got a slit there, we've improved it. There's still a bit of tilting there, there's still a little bit of scar there, but it's better. Here, we've almost got virtually no nasal airway through here. Again, asymmetric apertures still, but it's better. I never use the word perfect ever. I just say, hopefully, a lot better. And this is an example where Cottle maneuver was pulling this out here. This is using just a cotton tip to just hold out the nose and work out, does that majorly improve their nasal function? And these are the mute expanding splints that we're giving people to trial for their nose, and that's going to help with this area here. So this is an example of a lady where I thought that she had a previous surgery. I'd actually taken her parotid out of her about 15 years ago. Then she said, "Oh, can you fix my nose up?" And I thought she'd had previous surgery. I thought they'd actually remove all of her cartilage here overseas. But in fact, when I opened up, I realised, in fact, that her cartilage was indented. And so we needed to somehow evert these cartilages to get them better. And here we've got her more supported here so that her nose doesn't collapse inwards. We can have patients with a more trapezoid appearance. And again, we want to have more triangular appearance. And sometimes people who've had previous surgery, they've had a lot of tissue removed from their nose. The nose can retract upwards. You get too much columellar show, and we need to support and reconstruct the alar cartilages. Sometimes they're just very distorted. Again, you can see that you've got the impression that's very indented here. And so, of course, it's going to be the external valve, not the internal valve, that's going to be a problem. Here, again, previous surgery on the left, you can see it looks very pinched. It looks unnatural. You can see it's weak there, and we've given her more support out on the side here. Again, previous surgery, it's indented here. They've developed what's called bossy or knuckling, and we're just trying to get the nose looking as if nothing's ever happened. These days we're using more of these type of procedures, which is called a cruel turn-in flap. So we've got a patient whose nose, as you can see, is indented in the lateral compartment of the lateral cartilages. It's twisted, so we clearly need to straighten the septum. We've lifted up the alar here. I've folded in some cartilage here. And what I've done is, this is the unoperated side here. This part here I've folded in, so I've got a double layer here. I've scored this area here, and here we've done them on both sides, and we've got a strut here. And we're suddenly going from an asymmetric, twisted, bifid nose to a nose that's more symmetric. There's also what's called a repositioning manoeuvre. It's a more aggressive manoeuvre. What we're doing is, these are cephalically oriented cartilages, which are pointed that way, and they're sucking in. And so we're doing what's called a lateral cruel repositioning manoeuvre. We're lifting out the cartilages. It's quite aggressive. We're lifting them out completely. We're putting a strut graft. We're tunneling that in at a lower position. And this is going all the way down to the piriform aperture to, again, help support the nose to stop it collapsing in. You can see how it's broad, it's oriented upwards, it's weak out here, and a nose that just looks more natural. And it looks more natural here as well. It's less upturned and the profile's better. So if we're looking at aesthetics, I'm going to go from the top radix down to the dorsum, to the supratip, to the tip, and then the subnasal end. I'll just quickly run through a few examples. So here we've
Perry, excuse me, Perry, just a time update for you.
How much have I got? Have I got 5 minutes?
Yes, 5 minutes.
Okay, beautiful.
Thank you.
Okay, so we've got radix augmentation and dorsal reduction. Here we've got some profile adjustment. Again. We're going to talk about the tip, which is, we're talking about the width, the shape, projection, rotation. So I talk about nasal tips that are to something. So here we're under projected, so we're giving them better projection with columellar struts, previous surgery, and we've improved their support. Here we've got over projected tips that stick out too far, so we've brought them back. These are by segmental excisions to bring them all the way back. Some of them are just too wide. There's cephalic strips to bring them in and make them more triangular. There's domal definition sutures to, again, make them more triangular and aesthetically pleasing. We've got tiptosis, which we used to use a strut and hitch. So a bit like a banner, you lift it up. So here we've lifted the nose upwards. Again, from a toesed position, we've lifted them upwards. And this is an example of a cadaveric graft where I've used some multiple types of autologous material. And this is a nose, previous surgery, it drops right down and we've lifted it up. And if we've got someone whose nose is too high, we'll use extension grafts to bring the nose down. If they're too distorted, we'll try and somehow get the nose just to look a little bit more normal, dislocated here, again, bossy here. Fascia we'll use to the dorsum to, again, reconstruct previously operated noses where they're contoured and they're not working well. We'll use fascia, we'll use conchal cartilage, previously resected noses. We're going to augment them and make them more normal. And this is what I call the too hard basket. She'd had 6 previous operations. I took a rib graft and reconstructed her nose. And below the nose, what I call the 1%ers. Here we've got a person where we've very slightly lifted the nose so that the subnasally looks better. Here we've got a prominent anterior nasal spine where that looks better. Again, a prominent anterior nasal spine. It's the big ticket items are not the dorsum, but it's this nasolabial attitude that looks better. And if we combine them with frenulums, we can reduce the gum show on smiling by dividing the upper frenulum here. And we can also lengthen a short philtrum to give the nose slightly better definition, support, and projection. And I'm going to flick across from there and just, if I've got 30 seconds, I'll just say that the best thing I do is the Pacific work. People think that Vanuatu looks like that and like that, but reality is they're often living like this. These are the type of people that we're seeing here. That's at the hospital. These are the patients. Place belongs to the cutter man, is place belongs to the surgeon. That's the door of the operating theatre. These are the antiquated diathermy units that we were using 18 years ago. This is someone with big polyps that are coming out their nose. This is a guy with yaws, which is a treponemal infection that's eaten away his nose. This was me 18 years ago. That's a thyroid that I took out. We didn't have a drain, so I used an IV bag. This is a huge cholesteatoma and a mastoid. The drill broke down, so we had to use a Black & Decker drill. We often have an award for the biggest nasal bolster that the nurses fit on in their enthusiasm. And this is a young lady who had severe cystic fibrosis, huge polyps, nasal broadening. She wasn't fit for anaesthetic, so we did a nasal polypectomy and triple osteotomies under local sedation. That's her on the table with some oxygen filtering in. That's her at 6 days. This is my trusted nurse with a patient after a traditional ceremony. This is her at the hospital, fitting hearing aids. These are the nurses that we try and teach. This is my team. This is us giving some equipment to the nurses, and that's hopefully what we end up with. And that's me doing a handstand at the end of the last day, to the absolute shock of my anaesthetist. And they're very religious and very appreciative. And this was just a nice little piece of what's the word? I guess life aphorisms that she came up with. Thanks very much, guys. Appreciate you listening to me.
Wonderful, Perry. That was fantastic, and it's very interesting to see how our priorities are different depending on whether we're living in a first world or a third world. So I'm sure that the people that you help in Vanuatu have a different level of appreciation, and they're fortunate to have you. So we have one question before we move into the final part of my talk today. I think Selena had a question. Her question was, are you looking at taking adenoids out in adults? She wrote that adenoidectomy is very neat. The post-op was good for children, but are there any risks to adults? His ENT is refusing to remove them.
Rarely do we see adults with adenoids, they've almost always shrunk down to nothing. So it's very much a pediatric problem. So it's not that they're refusing to do it, it's more that there's likely no adenoid tissue there. But occasionally we do, and occasionally you're surprised, you know. I mean, I've had, you know, adenoids the size of walnuts in sleep apneic patients, and they wake up and not only have they been decorked in their oropharynx, but they say my nose is better as well. So I always check when I operate on patients, either preoperatively with a scope or intraoperatively when I'm actually doing the operation, to ensure there's no adenoid regrowth. But it's more that it's much more a pediatric problem.
Great, wonderful, Perry. Thank you for putting aside the time to
For having me. It's the first time I've ever been able to give a lecture in my Tracheodax.
Yes. Oh, same with me. What we'll do is in a couple of weeks' time, we'll have some more Q&A on a weekend session, and I'm sure there'll be more questions that will be directed towards you if you're free.
With pleasure. Thank you.
Great. Wonderful. Thank you. Thank you.